Welcome to Preparing for Board Certification in Advanced Diabetes Management. My name is Beverly Tomasian, and I'm a BCADM and have this certification for over 20 years. So very familiar with it, as well as I also have my certification as a CDCES, which many of you also do. So this webinar is designed to share with you the requirements to achieve a BCADM and a little bit of insight on the exam. We're here to help. We have a fantastic team. Brianna is celebrating 5 years as our Director of Operations, and Tiffany has been with us for over 6 months as our front person answering the phones and getting back to emails. And, just our team is so amazing. We couldn't do it without them. If you have questions, please reach out by phone or by email. And I always kick off with a land acknowledgement. We acknowledge and are mindful that Diabetes Education Services stands on lands that were originally occupied by the first people of this area, the Mechoopda. We recognize their distinctive spiritual relationship with this land, the flora, the fauna, and the waters that run through this area. This is our website. So on our website, there's a lot of free stuff, and I want you to find all the free stuff you can because it's really helpful. I use the free stuff in my clinical practice, and just so you all know, I work 1 day a week at a local Indian Health Services clinic providing one-on-one care. But here's our pocket cards, and y'all know you can download them for free, and we just updated them actually yesterday. We added the new indication for semaglutide that it now helps protect people with diabetes and chronic kidney disease. So we, can add our electronic updates in immediately, and our printed version, which is this, we update at least twice a year. So we print, probably 6,000 of these a year because people love them. They love keeping them in their pockets and referring to them. I refer to them because who could remember all these medications, the dosing, the side effects, and it's a great decision tool also. So those are free for download. We have a newsletter we write once a month, and in our newsletter, we include any sales that might be coming up. We have a free app, and this app I would highly recommend. We do a question of the week every Tuesday, rationale of the week on Thursdays, and there's also the standards of care in here and our cheat sheets, which we'll talk about in a minute. They're really helpful. Our company, Diabetes Education Services, is dedicated to inclusion, to promoting diversity, and also to recognizing social determinants of health in all of our educational offerings. Okay, we're having a Spreading the Love sale starting today, 20% off all of our online courses. We love having sales, and this is one of our most popular ones. So if you're interested in purchasing any of our bundles or extensions, it's a great time. The sale ends February 16th, so you have a little time. This is part of our online free university. So we have courses that you can pay for, and they offer CEs and other courses that are just informational. We want to get the knowledge out to all of you. We also have a course on preparing for CDCES. Many people are trying to figure out, should I do CDCES or BCADM? And we'll talk about the difference around those today. And many people might actually have both certifications like myself. And, that might play a role in your profession also. So I just like to say when we are offering our future webinar, so you can check that out if you're kind of on the fence. And also, if you can't attend the live, we always record our webinars so you can listen anytime. But for today, what we're going to talk about is qualifications to take the exam, applying for the exam, what's on it, how do you study, some test taking tips, and then a bunch of resources. This is exciting. This exciting news is that, drum roll, BCADM is now owned by the same organization that constructs the CDCES exam. Okay, so it changed ownership. It was with the ADCES, but CBDCE took it over, and that stands for Certification Board for Diabetes Care and Education. And so now, if you want to apply to take the BCADM, you go through this organization. And they have a cool new logo too for the BCADM. All right. Now, how does that change your life? Not too much, actually, but it's in good hands. The CBDCE is really excellent at sharing information and setting up a structure to take the exam that is pretty helpful. So I thought I'd kick it off talking about what is the definition of a BCADM? Well, these skillfully manage complex needs and assist people at risk for diabetes and with diabetes and other cardiometabolic conditions, and they help with therapeutic problem solving. This is really important too, because I saw some of you wanted to expand your scope of practice. Really, your scope of practice is determined by your licensure. So that's always something to consider. BCADM just kind of confers your knowledge and recognizes your advanced level knowledge. But within the scope of your licensure, people with BCADM may adjust and in some cases prescribe medication. So anyways, I have my master's degree, but my master's is in public health. So I can't prescribe any medication. I'm an RN and PH, but I can certainly make recommendations as a consultant to providers. But those of you who have, licensure, MPPA, MD, et cetera, of course, you can prescribe. So really licensure is what is dictating our prescriptive authority. So we can adjust if, we can make suggestions for adjustment or adjust medications, treat and monitor acute and chronic complications, other co-conditions, and counsel people living with diabetes on lifestyle, psychosocial, and participate in research and mentoring. And actually for renewal of your BCADM, a big focus is on leading the next generation of diabetes care and education specialists, training, research, and that a real focus on giving back to the community. So holding the BCADM, this was in bold on their application, so I wanted to just highlight this, does not confer a change in scope of practice beyond your current licensure or registration. So you might be asking, why should I do this? Like, why is it worth all the work and effort and money and resources to take this exam? Well, it does validate your knowledge, specialized knowledge and expertise, advanced level knowledge in managing people with diabetes and pre-diabetes. It could be used as a shorthand for hiring managers, showing that you have this expertise, and it can lead to increased compensation. Maybe there's a clinical ladder. And the benefits of BCADM, it is available to multiple disciplines. It's the same exam, regardless of your discipline, increases marketability and in the job search and visibility of the profession and organization. It helps fulfill increased need for advanced clinicians. I was just looking at this newsletter article that was saying we're really struggling having enough endocrinologists throughout the United States, and especially in rural and under-resourced areas. So I feel like our role can really help complement and fill in for the endocrinologists that are not present in our community, and certainly in the community where I work for Indian Health Services. Getting into an endocrinologist is very challenging. We have very few in this area, and it's really a struggle. I like this last one here, personal satisfaction. So like you all said, professional growth is something you want to take on to challenge yourself. When you see this little icon in the word handbook, this means I got this information directly from the handbook. So 2025, what are the qualifications? They really haven't changed since last year. You need your clinical licensure plus 500 clinical practice hours in advanced diabetes management within 4 years, 48 months prior to taking the exam. So here's a nice little summary chart of the eligibility requirements. And you can see if you're a nurse, you have to have a master's, dietitian need a master's, pharmacist, most pharmacists now are PharmD, but in the old days, we used to be, they had different options. So they would have to have a master's, PA or physician. So these are all the licensures that are eligible to take the exam. And then you can see here's a 500 practice hours within 4 years. And then here's the level of practice, which gives us a hint into what is advanced level practice. Well, we skillfully manage complex patient needs and assist people with therapeutic problem solving. Within our scope of practice, we may adjust medications, treat and monitor acute and chronic complications and other co-conditions, and counsel on lifestyle modification, psychosocial, and participate in research and mentoring. So that's, what this certification recognizes. So for the 500 hours, what is considered advanced management? How do you document your hours? And how will this expand my role? Let's talk about this. And is this version of the exam similar to the CDCES? Yes, that's my little cute dog, Chi-Chi, moving around in the background. So yeah, she always hangs out with me. But anyways, yes, they are very similar multiple choice testing situation, but you have a little bit less time with this exam, which is interesting. But to expand what I was saying earlier, what activities count toward hours? And this is right from the handbook again. Managing complex patient needs. And, you might look at complex data sets, you would formulate and create a problem list. But we have to be knowledgeable about nutrition therapy, pharmacologic therapy, exercise. We're going to assist with therapeutic problem solving, looking at behavior change models, and then adjusting medication if it's appropriate. So you might be saying, wait, some of this is what a CDCS does. And that is absolutely true. So this exam encompasses what a CDCS does and adds a little bit more, especially in the management side. So we're going to treat and monitor acute and chronic complications. We're going to perform comprehensive assessments, interpreting lab results. So we need to be familiar with lab results, not only for diabetes, but for thyroid, for cholesterol, for other co-conditions that people with diabetes experience, autoimmune issues. So we have to have expanded knowledge of diabetes and co-conditions that might be discovered, screened for, treated, and then treatment for those co-conditions. We have to be really familiar with pharmacologic interventions, and we also have to be familiar with nutrition therapy, referral to specialists, and so forth. So this exam covers the CDCS content, and it takes it to a step beyond with more of a focus, I would say, on medical management, but still always remembering to keep the person in the center and addressing psychosocial issues, looking at research, and mentoring future BCADMs. Okay, so I was excited. I think this was, I don't know, 5 years ago, maybe longer, maybe 10, when I renewed my BCADM. So I just wanted to tell you my history of how I came here. But I first took my BCADM in 2001. I already had my CDCS for over 5 years, but I wanted to grow my professional practice and my expertise. And then I had a strong background in inpatient management. And this is kind of relevant because since I had been working at Stanford Hospital as a diabetes nurse specialist there, so I was seeing all these really complicated people in acute crisis, but I wasn't working in an outpatient situation where I was managing individuals with chronic diabetes, and I wasn't working with peds or diabetes in pregnancy. And so I definitely had some knowledge deficits, but I studied for this exam and I passed the first time. I did pretty good, but I realized, man, I really need to increase the breadth of my knowledge. And it encouraged me to study more. And it encouraged me actually to create a course it's called Critical Assessment of Diabetes. And I still teach that course today. And it's a really helpful course it's standard 4 of the standards of care, which is medical assessment of people with diabetes. So it's looking at diabetes and the co-conditions and all the labs we want to keep a close eye on. I was part of an ANCC team and provided a review course with a few of my colleagues. I retook the exam in 2006. I passed. I did a lot better because I was so much more well prepared. And then starting in 2011, they don't let you take the exam to renew anymore. You have to keep doing all the different activities to renew, which includes getting CEs, teaching a college class, writing a book or a chapter in a book, teaching courses, and mentoring others and being involved in research. So all different kind of ways you can get your hours. So I last renewed in 2021. So guess what? I get to renew again in 2026. I'm looking forward to that. What are my roles? Like, what have I done? Well, y'all know I worked in a hospital setting. And after I left Stanford, I actually worked in a rural hospital up in Paradise, California, and it burnt down in the Camp Fire. But when I was there for 20 years, I ran their inpatient program. So I set up the inpatient policies and procedures, and we measured outcome data looking at glucose values and how well we were doing on inpatient management. And I also ran their ADA recognized outpatient program. So I did a little bit of both, and I did that on a 1 day a week. So I really, I had to hustle. We put it that way. There was a lot happening in a day on a daily, every Friday that I was there. I was there on Tuesdays. But we were able to accomplish a lot because I had a fantastic team. So whenever you have limited, time yourself, we just want to we want to identify people who can extend our reach. And, I worked with wonderful dietitians. Our program secretary was amazing. She really helped a lot. And then there was volunteers that helped too. And so in this role, I was wearing actually both of my hats. I was wearing my CDCS hat, providing the group classes and coaching, but I was also wearing my BCADM white lab coat because I was helping write policies and procedures, and I was measuring outcomes and doing research and providing consultation to complicated individuals. Currently, I'm working at an Indian Health Services clinic, and I would say there I wear more of my BCADM white lab coat because I'm seeing individuals one-on-one. I'm looking at their medication management, their co-conditions. I'm looking at their labs. Is anything undiscovered? Who would they benefit from seeing for further investigation of these issues that they might be bringing up? And so I am working at more of an advanced level in this situation, doing a lot of staff training, suggesting medication management, cardiovascular risk mitigation. I'm looking at liver enzymes and doing the FIB4 analysis and so forth. So yeah. And so in any given role, even if you don't have these certifications, you might be doing all of this. And I think this was the thing. Before I got my BCADM, I was doing a lot of advanced level care and management, but I didn't have the recognition. So the BCADM said, yeah, you are doing these things. You do have this additional knowledge that you are applying to the situation and really improving care. So I always say with the CDCS, we're wearing a coach's cap. We educate and support people affected by diabetes, promoting self-management. BCADM, we're more into medical management. It's more of a medical exam, and there's increased complexity of decision-making. You must have a master's degree to take the BCADM. So I like this little excerpt from AADE website. That was the old name for it. Now it's ADCS. The depth of knowledge and competence in advanced clinical practice and diabetes skills affords an increased complexity of decision-making, which contributes to better care. All right. And like I said, many of us are doing this advanced level care already without having the certification. So it's nice to be recognized. Becoming a BCADM provides opportunities for healthcare professionals to expand their roles beyond traditional boundaries and demonstrate their effectiveness in performing at an advanced level of practice. Now, how do you apply to take the BCADM? Well, you're going to go to the CBDCE website, and when you get there, you're going to see that there's a place to go on the Measure Learning portal, and then you'll apply for the exam. So how much does this cost? And it's cost $900. If you're a member of ADCES, which is actually much more economical to become a member, you only have to pay $600. That means you're paying $120 each year for 5 years to maintain the certification. Now, to take the exam in June, which I know lots of you are doing, you need to apply by May 1st. Try to get your stuff together early, apply before May 1st, because there is a late fee. Okay, and then you want to make sure that you sign up to take the exam ASAP so that you can choose a testing center of your choice and get a time that matches you. If you're taking the exam in December, you need to sign up by November 1st. Now, this is new, that there is a retake fee. So you can see what the initial fee costs, but for some reason you don't pass the exam, you can retake it, and you could take it for $340 if you're not an ADCS member, and $220 for ADCS members. So a nice discount there, which is terrific, because I don't remember reading that in the past. So I think that's very thoughtful. Now, do you have to turn in a bunch of information to sign up to take this exam? Well, you could get audited. 10% of people are going to be randomly chosen. Hopefully it's not you, but it could be. So be ready. Randomly chosen to submit this paperwork. So you'll need to have proof of licensure, somebody to attest that you've completed these 500 hours within the past 4 years. You need to have your diploma of a master's level degree or higher, and then you pay your fee, of course. And then here's a recertification, which is $100 less. After every 5 years, we have to recertify. Now, here's the question. Do you want to test live or do live online proctoring? And I've done both ways, so I'll let you know the pros and cons of each. So if you go to a testing site, you sign up for a site, hopefully near your home, so you don't have to drive too far. But once you get there, you'll have to put all your stuff in a locker. But at least you can stand up and stretch, you can move your body, you can use the restroom. Now, some testing sites are better than others. So, some are noisier than others, but most people have a good experience at testing sites. Just want to make sure you know how to get there. You want to arrive on time and have all your paperwork and ID ready for that person at the front desk. But there's also live online proctoring. So for this, you need to upload a bunch of software to your computer, have a secure room where nobody's going to walk in. They do not like if anybody walks in or the dog barks, you could be disqualified. Also, you need to have a webcam so they can see all around the room and nothing on your desk. The thing is, you have to have your face visible for the entire test. And there's no breaks. Now, when I was looking through all the paperwork, I didn't see them say that specifically in this new guidebook, but generally speaking, it makes sense, because you could imagine you could take a break and go look at a book, or look at your phone, get some answer that you're looking for. So for live remote proctoring, you need to have your face in the screen at all times. Nobody can walk in that room, and no loud noises or disruption. So you have a lot, and you can't stand up and move. So you have a lot less physical freedom, and it's really up to you. So you want to think, which situation would make me feel more calm and be better test taking environment for me? And that would just be a question, of course, only you know the answer to. And you want to consider bladder size, because you cannot use a restroom. That's another big issue. So just keeping all of that in mind when figuring out which way to go, because of course, if you do a testing site, you can't use the restroom. Now, the exam details. How many questions are there? There's 175 questions, but 25 of them don't count. They're just checking them out. But your score will only be based on the 150 scored questions. You have 3.5 hours to take this exam, and the CDCS has the exact same amount of questions, and they get 4 hours. So this is a little, you got to move a little bit more quickly. Minimum passing standard is set using a method called a modified Angoff technique. There's a diverse panel of professionals who possess a BCADM certification who are involved in the process of setting the passing standard. So they don't get your results right away, is what I'm taking a long time to say. They have to go through this process. So you're going to have to wait till the close of the testing window, and then they send your results 6 weeks later. So just want to let you know that. And that's a hard part. Results will be mailed 6 weeks after the close of the testing window, and then you can retake the exam 2 times in a year. Now, if you are still in the process of collecting your hours, if you go to our website, Diabetes Ed, and then go to free, and then go to BCADM page, you'll find this practice hours spreadsheet tracker, where you can it's like an Excel database you can download and track all your hours where you're doing advanced level diabetes management, looking at that list we talked about earlier. You don't have to put any names of the people that you serve. All you have to do is just write down approximate hours per day spent on providing diabetes care. That includes advanced diabetes care. That includes phone calling, faxing, charting, all of the, administrative stuff, all the stuff you do to provide individuals with that advanced level care. So what's on the exam? We know there's 175 questions, only of which 150 are actually scored. And how do they break up the content? Well, assessment and diagnosis is 30%, planning and intervention, 33%, 23% evaluation and follow-up, and then the smallest amount goes to population health advocacy and professional development. And so I thought you might want to see, all right, well, what does that mean? And here's the breakdown of how many questions on these different topics. And they haven't changed this as they changed over to the CBDCE that I could see. So I just want to say, if you'll notice throughout all of these, they're going to talk about social determinants of health. And that is, where a person works, lives, eats, prays, goes to school, gets their health care. It's their environment that they live within that can really impact their health and their health outcomes. And so we understand that when we look at an individual, their self-care is only a part of their health outcomes. Their environment plays almost a larger role than their self-care because it can impact their ability to engage in self-care. We have to be really familiar with the ADA, I'm just looking at my ADA standards of care and the A standards of care. And we need to be familiar with behavior change theory. So I have 2 free webinars that I would suggest you watch. You could just go to under free and look at these titles, Behavior Change Theories Made Easy. There will be behavior change theories on this exam. And what we say matters is the whole language movement, how we want to honor individuals with diabetes and choose words that lift people up. That's an important part of both exams, CDCS and BCADM. Okay, so planning and intervention, there's a lot of points going toward that, and that makes sense because we're going to see that person, and then based on our assessment of their situation, and we're looking at the whole picture, we're going to plan together in a collaborative fashion. And this is where we're going to incorporate behavior change, nutrition therapy, pharmacologic, surgical options, technology. Oh yeah, big part of this exam, technology. And you don't need to know specific pumps and CGMs and all of that, but you need to know the foundation of those devices, how they work, what to look for, the ambulatory glucose profile. So you need to be familiar with, in general, like how to problem solve and what to recommend to individuals based on their individual profiles. Okay, but look at this. I put in blue some changes from the previous version. Referral to mental health professionals for psychosocial issues, special populations. So our older adults, younger adults, pediatrics, people with disordered eating, people during pregnancy, those would be special populations. We need to be familiar with hospital care, DKA, HHS, insulin drifts, and also engaging in telehealth services. Evaluation and follow-up, another big chunk, 34 questions. Look at this, using technology devices to collect, analyze, and inform judgment. And so because we're advanced level and we're mentoring and we're leaders, we want to be very familiar with the use of technology and then evaluating the treatment plan. And then the last is on population health advocacy, professional development. And you can see here, we need to be familiar with the different organizations that oversee healthcare and make sure it's high quality. And also we need to be participating in scholarly activities and mentoring the future generation. Okay, we're halfway there. Let's do a little stretch break. Oh, that looks so good. Ooh, let's roll our shoulders back a little bit. That feels good. Okay, that's it. We're going to keep going. Okay, other questions that you might have. What standards are used and what year? So we always want to rely on the most recent year, but if you're familiar with the 2024 standards, they didn't change that much. Like there's no big clinical differences as far as blood pressure target or A1C. I mean, there's some modifications of recommendations, but what I'm trying to say, if you study 2024, you should be set, but always good to at least look at 2025 and see what are the revisions from 2024 and recommendations for change. And also, I have a very painless way for you to acquire what the differences are and what the latest information is on the standards. I have a 2-hour webinar called ADA Standards of Care Update, and it's in our level 2 series. I just recorded it. So that's really a nice summary of the critical standards you want to be familiar with. Okay, so what are the most important study tools? Well, I put my accordion pocket cards here because you want to know the medications on these pocket cards and the ADCS review guide. I have one here. Now, this review guide says it's for the CDCS exam, but I was just reading through the new handbook for this exam, the BCADM, and they said, know the CDCS stuff and add more information on an advanced level. So they recommend, utilizing the tool, this review guide, to increase your comfort with test taking. So there's 480 sample test questions in that book with the rationale. Super helpful to get just like reinvigorated as far as test taking goes, because many of us haven't taken a test for a long time. All right, so that's a review guide. What else do I have? Oh, wait, the ADA standards, I just want to say one more thing. You can get them for free on our app, CDCS Coach app, on our website. You can download them or, look at them. And then diabetes.org, that's the ADA website. We have a lot of great cheat sheets. And if you go to our website and it says, you go to diabetesed.net and hit free, you'll see cheat sheets on the right-hand side. And on that cheat sheet list, I have medication cheat sheets for blood pressure, lipid, and neuropathy. And we just reviewed them. I'm married to a pharmacist, a PharmD, and I made him review them. Oh, it's kind of funny, but I really did. I said, please, honey, because he hasn't reviewed them for a while. So he did, and they're up to date. Anyways, those are really helpful for this exam. Desk reference is from the ADCS. It's an 800-page book on diabetes to help you fill in knowledge gaps. Okay, we have a virtual conference. It's a 3-day conference. It's coming up in April, and it's myself, Diana Isaacs, and Christine Craig. So it's me, a pharmacist, and a dietitian. And we, for 3 days, talk about diabetes. And it's really fun and exciting information. This course will definitely help you with this exam. It's a really has a lot of information that's very applicable to the content of this exam. Okay, so what is the best source of information on newer medications? I would just download the pocket cards, and I know I create them, but it's just, we keep them up to date, and they have the most relevant information. And we also have a glucagon medication pocket card, so you're familiar with the 4 different medications for glucagon delivery. Okay, now here's that desk reference I was talking about, the 800-page. Here's a review guide. We no longer sell them as paper bundles. They are electronic only. So that book you saw earlier and it's my last one. I'm holding on to it. All right. This is the resource page that is in our website. You go under free BCADM resource. And this is really neat too, because look, it has the different domains and it has all the different topic areas that I've gone over. You can kind of assess your knowledge in each of these different domains to see what you need to study more of. And this is also where we have the practice hours spreadsheet tracker. Okay, right here. So you go to our website, diabetesed.net, free BCADM webinar and resources. This is where you get all this great stuff. If you go to the bottom of this page, so you get onto this page and you go all the way to the bottom past step 3, you'll get to step 4, articles to read to prepare for the exam. Look what we did. Man, this is awesome. We put like really critical articles to be familiar with, including our med cheat sheets, an introduction to medical statistics for healthcare professionals. Here's the ACE guidelines. And then this is the DSME. It's from 2022, but they only update it every 4 or 5 years. So you want to be familiar with that. And then here's a summary of revisions and the standards. We really want to spoil you. Let's just be frank. Okay, so here's the ADA 2025 goals. You just want to memorize these. A1C, these are the ABC goals. A1C less than 7, and here's a pre-meal and post-meal glucose, but for time and range, we want to have a 70% of the time, 70 to 180. Blood pressure, 130 over 80. We want to get that LDL less than 70 for anybody 40 years and older with diabetes. If a person has heart disease, we want to get that LDL less than 55. Okay, getting ready for the exam. This is right from the handbook, filling gaps in foundational knowledge. And this is where they say resources for exam prep for CDCS typically provide foundational information, standards, med use, and teaching skills. While they are not the focus of BCADM, foundational knowledge is helpful for meeting some of the content listed in the exam content outline. Now, they say for advanced knowledge, how are you going to fill in those knowledge gaps? Well, standards of care, you've got to read the standards of care. There's just no way out of it. And other guidelines like the ACE standards, regional activities, or online courses to fill in those advanced level knowledge gaps that you might have. Okay, so I just want to let you know that as far as test taking goes, I have a free test taking toolkit where I go over 20 sample practice questions. So that again, just go diabetesed.net, free test taking, and you can just listen to me break down test questions, 20 of them, and to help you just get familiar with how to work a question, as I call it. And I also have a test you can purchase, an online test that's 220 sample test questions. So some test taking tips: don't overanalyze or read into questions. The questions they're going to write are not meant to be tricky. They don't want to trick you. They just want to simulate you talking to a person with diabetes. Avoid adding in additional information beyond what's given in the test. Remember, this is an international exam. You want to be familiar with the national ADA standards, and we want to leave our standards and the goals we might be using in our own healthcare facility behind. When guessing, use a process of elimination. Treat each option as true or false statement and eliminate those you would not select. And then if there's key words that say best, most, primary, or usually, these words indicate other options may at times be correct, but you want to judge which option is best. You see, we're working with humans, so humans need some wiggle room. And so we want to be familiar with identifying unique characteristics of the individual, and also thinking about what is best. It doesn't say right, it says best. So that's, again, kind of a critical thinking approach where you want to, prioritize from best to worst. And so that's another ask they want is, do you know how to critically think and think what is best or most or primarily going to be the best answer? Skip difficult questions, come back to them later. And then test anxiety. Some people struggle with test anxiety, some people don't. If you're one of those individuals who do struggle with it, you're not alone. Know that, number one. And you want to plan ahead for how you're going to manage it. Getting enough sleep, avoiding alcohol, eating healthfully a few days before, keeping up your activity, really important. And then it talks about taking those deep breaths, putting your hand on your heart. You can even, if you're at a testing site, stand up, put your arms over your head. That tends to reduce our adrenaline levels, or putting your hands on your hip. And make sure you know how to get to the testing site. All right. So what they suggest to do is do a self-evaluation of your current knowledge in advanced diabetes to identify gaps, fill in those gaps, know your foundational knowledge, and that's kind of that CDCS part, but then find ways to fill in the additional advanced level knowledge, including pharmacology, complications, and comorbidities. And this is our test taking toolkit where we have 220 questions. Okay, let's practice some questions. I've been talking about test taking, and let's see how you do. Now, when you're taking a question, during this program, realize that no matter what answer you choose, it's going to be a learning opportunity. Even if you don't choose the best answer, you'll develop new knowledge. And if you do choose the best answer, it just reaffirms your knowledge. So this is meant to help you figure out, oh, how do I approach the test question? And also, how do I fill in some knowledge gaps if you do have them? So this is, you're just going to give yourself a ton of grace and just trust yourself and choose what you think is the best answer. A healthy adolescent with a 2-year history of type 1 diabetes returns for a quarterly appointment. For the past month, they have experienced abdominal pain and diarrhea after some high-carb meals. An advanced diabetes manager's first intervention is to order transglutaminase autoantibody test, B, 72-hour fecal fat collection, C, colonoscopy, or D, stool sample. Okay, let's go back and figure out what they're asking. So a healthy adolescent, she has a 2-year history of type 1 diabetes. They're coming back for a quarterly appointment. For the past month, they experienced abdominal pain, diarrhea after high-carb meals. What is our first intervention? So there, again, they're trying to make you prioritize. Let me launch this. Are we going to get a transglutaminase autoantibody test, a 72-hour fecal fat collection, colonoscopy, or stool sample? All right, let's see how we're doing. We'll wait a few more seconds. If you're not sure, just choose what you think is the best answer. See if you can get rid of 1 or 2 false answers. All right, I'm going to close the poll and share your results. So we have 75% of you chose A, 25% of you chose D. What is the best answer? It is a transglutaminase autoantibody test. So that's the best answer. I'm just looking if I can find my arrow here. Yes. Okay. That is the best answer. Finish my circle. It looks like a race car now. So why? Type 1, they have autoimmune diabetes, right? Immune-mediated diabetes. Now, we know with immune-mediated conditions, if a person has one, like type 1 diabetes, they're more likely to have thyroid disease and more likely to have celiac disease. So we're always on the lookout for those. They're often, correlated conditions. And so if the person is having GI pain, we might go, wow, okay, is that gastroparesis? That might be a thought, but then they give us more information. It's after high carb meals. And we know that carbs contain gluten, and gluten is very irritating to people with celiac disease. So celiac disease, an immune-mediated condition where people cannot tolerate gluten. It causes a lot of diarrhea and weight loss and malabsorption. And to evaluate that, we get a transglutaminase autoantibody test. And that you could kind of think, wait, type 1 is an autoimmune condition. This is an autoantibody test. That might give you some clues. But this is just kind of being familiar with co-conditions that are associated with diabetes, especially type 1 in this situation, and also what testing we would do. And that's a real big part of this exam. And so most of you chose that. Some of you said a stool sample. Okay, it's close, but we want to get a little more specific here and do the autoantibody testing. All right, let's do the next one. MJ is having trouble sleeping and complains of waking up with frequent nightmares. Insulin dose includes 5 to 8 units of Novolog at breakfast and dinner and 12 units of NPH at bedtime. Complains that before bed blood sugar is often greater than 300, so takes extra insulin before going to bed to bring it down. What is your best response? A, instruct MS to decrease NPH by 2 units to prevent nocturnal hypo. B, contact provider and request to discontinue NPH and start Lantus instead. C, assess if MS is having a snack before checking bedtime glucose. Or D, instruct how to safely adjust dinner time Novolog to prevent hyperglycemia at bed. Okay, MS is having trouble sleeping. They wake up with frequent nightmares. They're taking bolus insulin at breakfast and dinner and NPH at bedtime. Their bedtime blood sugar is often 300. So they take extra insulin before going to bed. What would you recommend? Would you instruct them to decrease the MPH by 2 units? Are we going to discontinue MPH, start Lantus? Are they having a snack? Or instruct how to safely adjust dinner time? All right, you're doing great. Okay, I'm going to close the poll because we're in a tie situation. So what is the tie? 50% of you said C, 50% of you said D. So let's see. So the C thing, assess if MS is having a snack before checking bedtime glucose. Well, let's just go back and see if we can figure out what's happening. They're having trouble sleeping. Why are they waking up with frequent nightmares? Well, frequent nightmares is a sign of nocturnal hypoglycemia. If people are getting low at night, they'll wake up hungry, they'll wake up shaky, they'll wake up sweaty, they'll wake up with nightmares, and they'll wake up with morning headaches. Okay, so we got this insight. They're probably getting low in the middle of the night. And then what they're doing is taking extra insulin before bed to bring their blood sugar down. Is that a good idea? Not really, because I don't know if they're taking extra basal or extra bolus. Like, I don't know which one they're taking, but either way, they're putting themselves at risk for hypoglycemia. How do we fix that? Well, the best way to fix that is to make sure they get enough bolus insulin before dinner so that their bedtime blood sugars aren't so elevated, and then they don't feel compelled to take extra insulin. So generally, I would really say, gosh, if you can avoid taking nighttime insulin to get your blood sugar down. Instead, take enough to cover that dinner and even some snacks you might be having. That would be a safer approach. So D is the best answer. And 50% of you chose that. And so that I'm going to just circle that. I can do that. D, yes. So that's the best answer. And if you chose C, I understand why you did, because you're like, wait, maybe she's taking a snack and then her blood sugars are going up. But that's not the best response. The best response is let's make sure she's taking enough insulin before dinner to get her nighttime sugars down. So you're so close. Let's do another poll question. The rates of gestational diabetes are increasing in the US. Which of the following is true? A, children born to people with GDM have lower rates of type 1. B, risk of GDM can be decreased by getting to healthy weight pre-pregnancy. C, GDM is defined as elevated blood glucose levels discovered any time during pregnancy. D, people with GDM can control glucose through diet changes only. Okay, it's a very straightforward question. We don't have to do a lot of double checking. What are they trying to say? Which of the following is true? So it's just kind of a true false thing. And you might want to approach it from that. Ask yourself, is this question true? Is this response true or false? All right, take a few more seconds. And even if you don't work with diabetes and pregnancy, just call upon your common sense. You have a lot of clinical knowledge and experience. All right, I'm going to go ahead and close the poll and share your results. So 50% of you said B, 50% said C. Wow, a lot of ties today. So nobody chose A, nobody chose, okay, 50%. So risk of gestational can be decreased by getting to healthy pre-pregnancy weight. Yes, that is the best answer, and half of you chose that. So there's lots of studies that show if people can enter pregnancy at a healthier weight, they're less likely to get gestational diabetes. But I do want to say something very important. There are many individuals who are at a healthy weight, who keep a healthy weight during pregnancy, who keep moving during pregnancy, and they still get gestational diabetes. It's nobody's fault. It's genetic. Plus, some people are just more likely to express gestational diabetes. Maybe they don't have enough beta cells on their pancreas to really match that insulin resistance associated with pregnancy. So, but we do know, just looking at epidemiologic data, that people going into pregnancy at higher weights have a higher risk. So really trying to help people as they move toward pregnancy to get to their healthiest self that they can is a really good idea. And then 50% of you chose C. Gestational diabetes is not elevated blood sugar discovered at any time. It's very specific. It's when we measure blood glucose levels using oral glucose tolerance tests at 24 to 28 weeks. Why do we do it then? Because the hormones, the pregnancy hormones, are at a peak at that time, increasing that person's rate and likelihood of expressing diabetes or insulin associated with insulin resistance, because the pregnancy hormones make us more insulin resistant, and that's when the blood sugars are most likely to go above target ranges, 24 to 28 weeks. So that's what gestational diabetes is. But the American Diabetes Association recommends everybody, when they discover they're pregnant, gets their blood sugar checked immediately, as soon as they discover they're pregnant, preferably before 15 weeks, because there's people out there who become pregnant who have diabetes and don't know it. So that would be pre-existing diabetes, and then they get pregnant, which is different than gestational diabetes, which is discovered at 24 to 28 weeks. So listen, if you're not that familiar with diabetes and pregnancy, you can read the standards of care. They have a whole standard dedicated to that. And we have a bunch of courses that go over diabetes and pregnancy and the other topics I've been talking about within our online university. I'll be going over that more. So this is just you identifying knowledge gaps and how am I going to fill those in? Okay, let's do poll question 4. Hyperglycemia during hospitalization is associated with poor outcomes due to what? Abnormal co-regulation of nitric oxide. B, increased free fatty acids, ketones, and lactate. C, ketone production associated with alkalosis. D, increased insulin resistance and insulin secretion and decreased counterregulatory hormones. Okay, hyperglycemia during hospitalization is associated with poor outcomes. A, abnormal co-regulation of nitric oxide, increased free fatty acids, ketones, and lactate. C, ketone production associated with alkalosis. Or D, increased insulin resistance and insulin secretion and decreased counterregulatory hormones. Now, the reason I'm reading it to you twice is that's what I want you to do at the exam. Read it once and read it twice. And on the second time, the best answer might appear to you. All right, wait a few more seconds. Okay, half of you have voted, so I'm giving a shout out to the other half to see if you can choose the best answer. And if it's not the right one, it's totally okay. Thank you. Okay, I'm closing the poll, sharing the results. So 80% of you chose B, 20% of you chose D. So let's just look at D. This is a very common thing they will do. They'll give you an answer with many different parts to it, and they'll make 2 parts right and 1 part wrong. So when people are in hospitals, they have increased insulin resistance. Yep, they're going to have a lot of counterregulatory hormones being released, so that increases resistance to insulin. And they might actually be secreting more insulin to overcome the resistance, but they do not have decreased counterregulatory hormones. No, they would also have increased, cortisol, growth hormone, epinephrine, all of those hormones that cause us to have elevated blood sugars. So that's where it's wrong. That word decrease, you're like, they got me right there. But the best answer, 80% of you chose, is B, increased free fatty acids, ketones, and lactate. Yes, because there is more insulin resistance, and maybe the body can't use glucose as effectively for fuel, so it's going to be using fat for fuel, which can lead to ketones, acids, and lactate. Okay, let's do another one. JR is 48. He's 40 years old and has a 10-year history of diabetes. And you might be asking, why is Beverly talking about MPH? Because MPH shows up on the certification exam. So I'm trying to get you comfortable with MPH. So y'all know it lasts for about 10 hours, but it has a peak around 4 hours. So generally, it's a twice a day basal insulin with a peak, so the increased risk of hypoglycemia. And it is cloudy. And you can read more on the pocket card. All right, getting back to this question. They inject 16 units of MPH and 8 units of Lispro before breakfast, 8 units of MPH and 4 units of Lispro before dinner. What's their blood glucose pattern? Fasting is 100, pre-lunch is 240, pre-dinner is 210, bedtime 150. This is a very common type of question you'll see. The advanced diabetes manager recommends what? Adding 2 units of Humalog before breakfast, B, adding 4 units of Humalog before dinner, C, adding 2 units of Humalog before lunch, or D, decreasing the evening MPH insulin by 2 units. So they're on basal bolus in the morning, basal bolus before dinner. And then we see their pattern. And then what change would you make in their insulin to help improve their blood glucose levels? All right, I'm going to launch the poll. All right. Be bold. Choose an answer. I don't see individual responses, just so you know. It's cumulative. All right, I'm closing the poll. Thank you all. I'm sharing your results. 80% of you said A, 20% of you said D. Let's just take a look at this and see where is the blood glucose above target. We know we want before meal blood sugars 80 to 130. So fasting is great, 100. But pre-lunch, 80 to 130, it's way above that. And so is pre-dinner. Bedtime, we want that less than 180. So our only 2 numbers outside of target are right here. And what's the highest one? It's the lunch. So how are we going to get the lunch blood glucose down? Well, to get pre-lunch blood glucose down, we need to add 2 units of Humalog before breakfast. And 80% of you chose that. Great job. 20% of you said, well, decrease the evening MPH by 2 units. I'm not sure. Maybe you were worried about that morning blood sugar a little bit. But the main issue here, I mean, I'm when I said you're worried about low blood sugar, I meant, you don't want to let this get too low, less than 100. But the target in the morning is 80 to 130. So the thing we're going to worry about, because there's not really hypoglycemia, is hyperglycemia. And the highest number is lunch, before lunch. And so we're going to give a 2 units of extra bolus before breakfast. Okay, great job. Okay, this is a math question. So let's get our calculators ready. And if you're taking the exam, they'll either have an in-screen calculator or a calculator provided. Of course, you can't use your phone, darn it. ML takes 16 units of blue lysine before breakfast and lunch. They take 16 to 20 units before dinner, depending on their blood glucose levels. ML also takes 42 units of glargine at bedtime. How many vials of glue lysine does ML need a month? 1.5 vials, 2 vials, 2.8 vials, or 3 vials? So any math should be worked out on scratch paper. I'm going to do it with you right now. I'm going to leave this up for a little while. So they take 16 units of glue lysine before breakfast and lunch, and they take 16 to 20 units before dinner, depending on their blood glucose. and they take 42 units of glargine at bedtime. So how many vials of glue lysine does ML need a month? Okay, I'm going to launch the poll. This is important for us to know as consultants, as providers, because we want to make sure people have enough insulin to last them for a month. It's really important. All right, we'll wait a few more seconds. Well, less than half of you have chosen the best answer. So I'm going to just say, if you can, just choose what you think is the best answer. All right, I'm gonna have to close the poll. Okay, thank you. So here's your results. I'll share them. 75% of you said 2 vials, 25% of you said 2.8 vials. Okay, so let's just take a look at this. This person takes 16 units of glue lysine before breakfast and lunch. So 16 at lunch, 16 at breakfast, that equals, let's see if I can write this, 32 units. 32. It's just crazy ways doing that. Okay, and then they take another 20 before dinner. So 32 plus 20 is 52. And then so that 52 units a day, you have to use the max that they take before dinner, right? Because they might take 20 units every day that month. So 52 units a day of this bolus insulin, glue lysine. So how many days are in a month? Well, there's 30. So what's 30 times 52? And you could just do like simple math in your head. Let's like say it's 1500 and change, right? So it's 1560. All right, now we know that person needs 1,560 units a month of insulin. How many units of insulin is in a vial? How many units? There's 1,000 units in one vial. So if they're using 1,500 units, they'll need 2 vials. We always want to give a little extra wiggle room. So they're going to need 2 vials of insulin. And some of you chose 2.8, and that, you might have added in this 42 units of glargine. Maybe you just included that in your math calculation. So they're just asking for glue lysine. So that's a really important too, when you're looking at these type of mathematical questions that might trigger some anxiety. So make sure that you read it really carefully and just utilize the insulin they're asking about. And so, yeah, this person would need 2 vials a month. And if they're using pens, every time a person uses a pen, they're supposed to do a 2-unit air shot, and there's not additional insulin in the pen to account for that. I mean, not in all pens. I think one of the pens does have a little bit additional to cover that, but we will also want to, if they're using insulin pens, add in that extra 2 units before every shot, the air shot, to make sure their needles are patent. Okay, so what is the best answer? Looking at this messy page, it's 2 vials is the best answer. Yeah, okay, here we go. We have a 54-year-old, BMI 32, with type 2 diabetes, A1C 8.3, history of hypertension, UACR 38, GFR 49. Meds include glipizide, metformin, levothyroxine. Given his risk status, which 3 classes of meds should they be taking according to ADA standards? Insulin, aspirin, and ACE, TZD, ARB, and bolus insulin. C, beta blocker, stop metformin, atorvastatin. D, ARB, statin, SGLT2 inhibitor. Let's just go back. 54 years old, BMI is 32, type 2 diabetes, A1C 8.3, history of hypertension with a UACR of 38 and GFR 49. And here's their meds. What 3 classes of meds should they be taking? All right, let's launch this poll. See what y'all have to say about this one. All right, I'm closing the poll because you guys are on fire. 100% of you chose D. Great job. Okay, let's just take a look at this. So the A1C is above target. They have hypertension. Now the UACR, really important to know that we want that less than 30. That's urinary albumin creatinine ratio. So if it's greater than 30, that person is having some degree of kidney failure, and we look at their GFR. We want that 60 or greater. It's 49. Their meds include glipizide, sulfonylurea, metformin, biguanide, and then something for thyroid. Boy, what are they missing? So for hypertension, person with diabetes should be on an ACE or an ARB, especially if their kidney function is diminishing. And they need to be on something for their cholesterol. I don't see any lipid medication here. Anybody 40 years or older with diabetes needs to be on a statin. And then also with the kidney function, we need to get them on an SGLT2. So great job, team. You chose D, 100% of you. And if you, 50% of you voted, so I'm not sure if you were thinking about a different answer, but this is how you would kind of break that down, looking at their kidney function, their lipid management, their hypertension. So the ABCs of diabetes, adding on, of course, the K for kidneys. Oh, yeah. So this is just to remind us that we have questions of the week and resources on our CDCS Coach app. There's the standards of care. There's our pocket cards. There's our cheat sheets. It just goes on and on. Let's do one more. I think we have two more questions. Okay, you're doing great. We have, this is straightforward. Current recommendations for screening for type 2 diabetes and prediabetes in asymptomatic young adults includes elevated BMI plus what? Individuals with the HDL of 52, women with polycystic ovary disease, individuals with a history of Addison's disease, offspring with the parent with type 1 diabetes. So very straightforward screening question. We want to screen for type 2 diabetes and prediabetes in asymptomatic young adults, and it's going to include a person with the BMI that's elevated plus what would make us, we better check out this person and see if they have elevated blood glucose levels. All right. If you haven't chosen one, now's your chance to choose one of the responses. All right, I'm going to have to close the poll and show your results. 100% of you chose B, but I do need to say that only 38% of you voted. So when I see that, I feel like, people aren't sure. So just so you know that PCOS, people with PCOS disease, polycystic ovaries often have insulin resistance. They have more androgen hormones, and so that causes increased risk of insulin resistance, and they might have facial hair or chest hair, acanthosis nigricans, all putting them at higher risk of having diabetes. So B is the best answer. Let's do one more. I know I usually this takes about an hour and 15 minutes to go over. So thank you for hanging out with me. RS observes Ramadan and fasts from sunrise to sunset. They're 13 years old, have type 1, uses an insulin pump. Insulin to carb ratio is 1 to 12, correction is 1 to 45. Here's our basal settings, 0.5 to 1.2 units an hour. What would be the best recommendation to keep RS's blood sugars in target range during Ramadan? There's actually a big focus of this on the standards of care this year. A, see if RS can get a note from their doctor to allow eating during the day. B, decrease basal insulin by 50% during periods of fasting. C, take bolus insulin when RS eats a meal or snack. D, monitor urine ketones at least twice a day. And I'm going to just launch this in the interest of time. So during Ramadan, what would be the best approach? So they're going to fast from sunrise to sunset. Note from their doctor, decrease basal rate by 50%, take bolus insulin when they eat a meal or snack, monitor urine ketones at least twice a day. Okay, I'm closing the poll. This is a tie. We had a lot of ties today. 50% of you said B, 50% of you said C. All right, so let's just take a look at B. We might decrease the basal rate. That might be an option, but would we decrease it by 50% for somebody with type 1 diabetes? No, that would be very dramatic. And basal insulin, if it's calculated correctly, will not cause low blood sugar in periods of fasting. Basal insulin is really to keep the liver from making too much sugar in between meals and through the night. So basal insulin is not associated with food. So if I'm fasting, I don't really need to decrease my basal insulin that much, maybe 10 or 20% for some individuals, but 50% would just be too big. So other 50% of you chose C, and C is the best answer. The most important thing here is that they just take their bolus insulin when they eat a meal or snack. So they would keep their basal insulin going to maintain blood sugars in between meals and through the night. And then they would just take that bolus insulin when they break their fast, and they would associate that bolus insulin with the carbohydrates and other qualities of the food they're consuming. So this is the best answer for C, and half of you chose that. So great job, team. We made it through the test taking portion. I just want to share a few resources to prepare for the exam and let you know that you need to recertify every 5 years, and this is the way that you do it. And we have a certification exam study group on our Facebook page. It's so great. It's people who are taking BCADM or CDCS, and they share insights and tips and give all kinds of support. It's amazing. It's like over 1,400 people in there are 1,400 individuals are participating. I just wanted to share with you how we structure our online university, because you might be thinking, oh, there's some knowledge gaps I really want to fill in. And we've been doing this for a long time. So we kind of have it figured out, like what people need and what really helps them. And just like what we were talking about in the introduction from the CBDCE, they said, much of this exam has some fundamental knowledge that you need to be familiar with. And that's what we cover in our level 1. And you might be familiar with this knowledge. You've been maybe working in diabetes for a long time. So you kind of have to assess, where do you want to start? Level 2, though, everyone needs to dive into, because this is where I go over the standards of care and I break it down. Now, the thing is, I've been reading the standards of care for a long time, like 30 years. So I am very familiar with them, and I know what's changed, what's most important. And that's also from my exam taking experience. So I really provide you with a lot of tools to figure out, what do I study from the standards of care? And it can be very, very helpful for you. People often, if you look at like comments that people say, what helped you the most to prepare for the exam, they often bring up level 2 and level 3. Level 3 is, we used to call it the boot camp, but we changed it to diabetes mastery and certification readiness. So you're ready to take the exam, 3 to 6 months. This boot camp is so great for you. We're going to kick it off tomorrow. Wow, I better get ready. Kicking it off, and it's 9 sessions. So it's 9 sessions of intense information. I do 9 poll questions per class, and then you have another additional, 8 to 12 questions after class. And the class 9, I do a test taking coach session. Really super helpful. Level 4 is our advanced level, where I've really designed it for people taking their BCADM. It includes standards of care, but it goes beyond. It's more advanced level, more nitty gritty insulin calculation, and more medical management of people with diabetes. So that is also available as part of the packages, because we package them up for you, so you don't have to figure out, what do I do? Sometimes I go to shopping carts, I'm like, wait, I just want to get the package. Where's the package? So I get that. And we have the BCADM Bootcamp bundle right here, which is level 2, 3, and 4. CDCS is levels 1, 2, and 3, or you could get the dual certification if you're thinking about doing both, which includes all levels. And the reason we bundle these up, it's easy for you to navigate, but really important too, it's a cost savings. This is our virtual conference. It's happening April 16th through 18th. As I mentioned, very excellent course for preparing for BCADM. The good news is you get 20% off all of our online courses and extensions starting today. The sale ends February 16th, but if you're watching this as a recorded version, we offer sales throughout the year, and we always have a Cyber Monday blowout sale, 30% off. The thing is, we're here to support you on your journey, whether it's CDCS or BCADM. I mean, we have so many fantastic stories on our webpage of people who've taken these exams and succeeded and kind of shared their story. We are very generative in that we're constantly writing blogs, sharing information, question of the week, newsletters, it just goes on and on. And these are all of our links to where we share our information. You're going to do great. You came to this program, you muscled through an hour and 20 minutes. You stayed with it. And that tells me you're the kind of person who wants to be prepared. You want to get the inside knowledge. You want to do everything you can to succeed. We're here to help you. If you have questions, please reach out. We want to answer them and serve you. So I'm going to hang out to answer any additional questions. But for now, thank you so much for joining us and advocating on behalf of people with diabetes. You're making a big difference. This is Beverly Tomasian signing off.